Gastric dilatation and volvus by Devin Gregory. Gastric dilatation has many factors. This is where food and gases expand the stomach, resulting in abdomen blood loss and dysfunction and difficulty breathing. This can suddenly cause the stomach to rotate on itself. If the stomach becomes enlarged enough, this rotation is called volvulus and prevents the release of these food and gas particles. Although the initial cause of this is unknown, it is said that the volvulus occurs first, resulting in the dilatation of the stomach. This impacts the GI tract from the esophagus to the stomach and can compress the spleen. The entrance and exit of the stomach twist along the duodenum and by wrapping over the fundus. The entrance is the esophagus, the exit is the pylorus, the duodenum is the beginning of the small intestines, and the fundus is the top of the stomach. The direction of this rotation begins with the pylorus and the duodenum migrating ventrally and cranially. Next, the stomach rotates between 90 to 360 degrees in a caudal to cranial view in a clockwise fashion around the distal esophagus. Then the displacement of the pylorus to the left of the midline and entrapping the duodenum, esophagus, and stomach. Rotation of less than 180 degrees will block the distal esophagus. The spleen may shift due to compression of the stomach as well. This is a chronic and life-threatening condition that causes obstruction due to compression of the duodenum and the caudal vena cava, which is the blood flow from the bottom to the top. This causes pyloric stenosis, the thickening of the duodenum, pressure on the spleen entrapping it, and lack of venous return or blood flow, further resulting in blood in the viscera, internal organs, renal, and posterior muscular capillary beds, causing slow blood flow, low blood volume, and abnormally low blood pressure. Upon examination, there may be a distended or gas-filled abdominal pain. Upon palpation, you may examine an enlarged spleen, also signs of anorexia, and retching without producing anything. This, combined with the lack of fluids, can result in hypovolemic shock. This looks like tachycardia or prolonged capillaries, blood mucus, or even shortness of breath. Diagnostic testing are radiographs and blood screening. The radiographs view the right side with the canine laying on the stomach and avoiding laying them on their back in case of vomiting. Blood screening include PCV, CDC, serum lactate levels, and more. Also, blood screening will show increased nitrogen levels in the blood, increased CK levels, serum potassium increase, ALT and AST increase, lactate in the blood, gastric necrosis. The right lateral radiograph will show a large gas-filled shadow with the pylorus located back and slightly forward to the fundus. The gastric shadow between the pylorus and the fundus is a soft tissue shelved or backward C, as it is now twisted. Also, movement of the spleen may be noted. Two ways to decompress the stomach, and this depends on if a orogastric tube can be passed through the esophagus. If not, then a needle can be punctured through the stomach, known as gastrocentesis, followed with lavage. Surgery must then be done to derotate the stomach and then suture the stomach wall to the abdomen, known as gastropexy. This can be prevented with a few practices such as feeding multiple small meals rather than one large meal, or restriction of exercise before and after meals. Surgery, there are antibiotics and sedation given. Antibiotics will continue 2 to 3 days after surgery. Cardiac arrhythmias are common and can be treated with a large dose of lidocaine and repeated twice in a 30-minute period. Life-threatening arrhythmias sometimes will respond to magnesium sulfate over a 5 to 15-minute period. Also, antiemetic metoclopramide at a 0.2 to 0.5 milligram per kilogram may be administered by injection in case of vomiting. General understanding of where GDV initially comes is not understood, but there are phenotypic and environmental risk factors that can be outlined the condition. Risks are in larger breeds and canines with close relation to a dog who has the condition or with history of this condition. A list below are high-risk breeds.